Now, we will talk about obtaining the cardiac views. You can practice your echo skills by developing a systematic protocol. A suggested approach can begin with the parasternal long axis view, rotate the probe 90 degrees for short axis, move on down to the apical forechamber, and then finish up with the subxiphoid window. Let's start with the parasternal long axis view. Start out in cardiac mode. The indicator should be on the right of the screen, and then the probe indicator on the patient's body should be facing the right shoulder. Start by placing the probe at the nipple line or fourth intercostal space, or in women, the inframammary line, right next to the sternum. Keep the probe perpendicular to the skin and hug the sternum as you go up and down the chest, searching for the best window. So I told you I would give you an easy way to remember the parasternal long axis view. You can remember it by the 3 L's to success. The parasternal long axis should have the left ventricle on the left side of the screen. Before we go identifying what we see on the image, it may be helpful to see a schematic representation on the ultrasound image. We will see the right ventricle with the left ventricle beneath or deeper to it, and the interventricular septum in between. In the left ventricle, you can see the mitral valve and sometimes the papillary muscles. To the right of the mitral valves, you will see the left atrium. In this image, you can also see the aortic valves and the aortic outflow tract. Going back to the ultrasound image, if we again imagine the heart as a cone, the apex is at the upper left of the screen, with the base towards the lower right. Anteriorly is at the top of the screen, and deeper or towards the bottom of the image is the posterior portion of the heart. The items to identify in the parasternal long axis view are the left ventricle, the right ventricle, the aortic valve and the mitral valve, the left atrium, the interventricular septum, the descending aorta, which will be important for distinguishing between a pericardial effusion and a pleural effusion. We'll talk about that later. The aortic outflow tract, and the pericardium. The parasternal long axis view is great for estimating ejection fraction. There are a few studies that show that eyeballing the ejection fraction by looking at the squeeze of the heart and how closely the anterior mitral valve leaflet gets to the interventricular septum is a good estimate of the gold standard cardiology method of evaluating the EF. Additionally, it is much faster and can easily be done in the emergency setting. In this ultrasound image, you can see that the anterior mitral valve leaflet is slapping up against the interventricular septum. You can also see that there is good squeeze of the left ventricle and that the ventricular walls are almost touching with each contraction. This is indicative of a normal ejection fraction of greater than 50%. In this ultrasound image, the anterior mitral valve leaflet does not quite make it to the interventricular septum. Additionally, the squeeze of the ventricles just isn't as good as the last image. This EF is consistent with moderately depressed at 30 to 50%. Look at the next image. In this image, there's very little motion of the mitral valve leaflets and hardly any squeeze of the ventricles at all. This is a sick heart with an ejection fraction of probably less than 30. If you want to quantitatively measure the ejection fraction and not exactly eyeball it, you can do so using EPSS, or E-point septal separation. This is a heart in the parasternal long axis view. If we want to use EPSS, we just throw down an M-mode spike at the tip of the anterior mitral valve leaflet, and this is what you will see. The thicker white line represents the interventricular septum, and the squiggly wavy lines beneath that represents the motion of the anterior mitral valve leaflet. The anterior mitral valve leaflet slaps twice on the interventricular septum in a normal heart. The E represents the passive filling of the ventricles, and A represents the atrial contraction. The distance between the IVS and the squiggly lines show just how close the anterior mitral valve leaflet gets to the interventricular septum. A distance of less than 7 millimeters is considered normal, and greater than 10 is considered LV dysfunction or reduced EF. 7 to 10 is sort of a gray area and needs to be taken into context. This is another example of reduced ejection fraction. CHF is not the only way that your patient can end up with a reduced EF. If your patient has aortic regurgitation, the backflow of blood will inhibit the anterior mitral valve leaflet from opening fully. This will make your EPSS larger even though there is no CHF. Or, if your patient has mitral stenosis, the poor excursion of the mitral valve leaflets will give you a large EPSS, falsely predicting cardiac ejection fraction.